Good afternoon. My name is Rebecca Licky. I am a national program consultant with the American Heart Association, and I will be your moderator for this session. On behalf of the American Heart Association, I would like to welcome you to the second session of today's Close the Space Secondary Prevention of ASCVD Care Education Virtual Summit. All presentations will be recorded and available in the coming weeks at heart.org/ASCVD. It is now my pleasure to introduce our speaker for today, Dr. Nishant Shah. Dr. Shah is a faculty member at Duke Medical Center, Division of Cardiology, and is an expert in preventative cardiology as a member of the Cardiometabolic Prevention Program. He obtained his medical degree from Wake Forest University School of Medicine, internal medicine residency training at Johns Hopkins Osler Program, and his cardiology fellowship training at Cleveland Clinic. Dr. Shah's research revolves around the clinical manifestations of genetic lipid biomarkers, lipoprotein A, and advanced dyslipidemias. Dr. Shah also serves as an associate editor for the American Heart Journal and is heavily involved clinically at both the outpatient and inpatient level at Duke Heart Center. Dr. Nishant Shah, the floor is yours.
Thank you so much for that extremely kind introduction, Rebecca. It's such an honor to be here today with all of you and to talk about statin intensification and ways we can meet our LDL-C goal, which is extremely important in patients with ASCVD. These are my disclosures. The purpose of my presentation today is purely educational. So I want to just start off by defining what ASCVD actually is. So at ASCVD, for many on the call who know, is atherosclerotic cardiovascular disease. And it is a combination of a multitude of conditions. So non-fatal myocardial infarction, non-fatal stroke, TIA, peripheral arterial disease, non-obstructive CAD, aortic atherosclerosis and aneurysms, carotid disease, and any other coronary or other particular like peripheral arterial revascularization. So very loaded term. And we have, through the American Heart Association, American College of Cardiology, we've developed a risk calculator that you guys have also probably all commonly heard of. And this is mainly for patients with in primary prevention, not necessarily patients with established ASCVD, but I think for the purposes of just understanding statin intensification and why we need to intensify, I think it's important to just talk about. But you know, in a patient who has not had an event, this calculator can be helpful to just get an understanding of baseline risk. And so it's important to remember, however, that this risk calculator has some caveats, in that it assumes that the patient does not have established ASCVD, is between the ages of 40 and 75, is ideally not on a statin therapy, doesn't have an extremely elevated total cholesterol. And it's important to note that at extremes of ages, there can be an underestimation or overestimation risk. And again, the importance in all of this risk assessment and statin intensification and choosing therapy is mainly done with the foundation of shared decision making. So the idea is it's not necessarily to tell you what to do, but help you guide or be a guide for your decisions. So this is an example of what the important parameters of the ASCVD risk calculator include. So gender, age, race, lipid panel, particularly the total cholesterol, LDL and HDL, and whether or not they're on a statin, blood pressure, and prior history of smoking, diabetes, or aspirin treatment, and hypertension. And with that, we get an estimated 10-year risk, and that goes into 4 different buckets. So the low risk or less than 5% risk of an event, 10 years, borderline 5 to 7.5, intermediate 7.5 to 20, and high, greater than 20%. Again, this is assuming a primary prevention patient without diabetes between the ages of 40 to 75 and who have an LDL anywhere between 70 and 190. What do we do though? What do we do with those buckets of risk? What's kind of the guideline-based recommendation on how we should move forward? So if someone is at low risk, again, it's important to have that discussion with them and emphasize the importance of good lifestyle modifications, evidence-based lifestyle modifications that can prove to better outcomes. At borderline risk, Again, a good patient-centered discussion. And this is where you would start to consider, and I would argue even in the low risk, if there's other risk enhancers that are not included in the ASCVD risk calculator that could increase someone's risk more than what meets the eye, if you will. An intermediate, again, having that risk discussion, identifying silent risk enhancers, but it's also not unreasonable to go ahead and start moderate intensity statin in this particular patient population with the goal to reduce LDL by 30 to 49%. And of course, high risk patients, those with greater than 20% risk, assuming you do nothing, having that risk discussion and hopefully initiating a statin at first line to reduce the LDL by at least 50% if possible. I talked a lot about risk enhancers, and this is important to keep in mind because these are things that are not included in any of the risk calculator. And they include things like premature family history of coronary disease, a persistently elevated LDL, chronic kidney disease, metabolic syndrome. I always tell my fellows and residents, hey, you got to know what a patient's, especially our female patients who, and our patients that can get pregnant, what their pregnancy history was like. And also what the menopause history was like. Was it premature? Did it have a history of preeclampsia, gestational hypertension, gestational diabetes? All these things increase risk. Inflammatory diseases, ethnicity, South Asian ethnicities in particular have a higher risk, and then certain biomarker patterns. So elevated high sensitivity CRP, looking at their lipids, high triglycerides greater than 175, an LPA or lipoprotein A greater than 50 milligrams per deciliter, an ApoB greater than 130. And of course, if they've had ankle brachial indexes, those that are less than 0.9, those are extremely important, very important. And I would say these risk enhancers, I mentioned them, in the context of a primary prevention patient, but if you have a secondary prevention patient or someone with established ASCVD, these are the things that really, really, really will screen residual risk and really should emphasize the importance of lowering our LDL cholesterol as low as we possibly can to help optimize our patients. But we've all perhaps have heard this from our patients. We've all heard a comment, perhaps, maybe I just don't know if I want to be on a statin, or hey, I'm otherwise physically active. Yeah, I just had an MI, but I'm eating a plant-based diet. I've heard and read a lot of negative things about certain lipid-lowering therapies. Will this medicine actually help me? I need proof. Now, again, this is meant more for the primary prevention patient, but this may be a good opportunity to do a calcium score. And I apologize for some of the overlap here of the slide, but a calcium score in someone who's not had established ASCVD is a two-way recommendation, especially if they're hesitant to be on a statin or where the benefit of a statin appears to be unclear. And a calcium score has come with a lot of data more recently, the prognostic utility of a calcium score. This is just some early data of two big cohorts, one that was followed for 5 years and the other was followed for 12 years. And if you look across this entire patient population, both the 5-year follow-up group and the 12-year follow-up group, the top line here of the Kaplan-Meier curve is someone with 0 coronary calcium. And the calcium score increases in a graded fashion as the all-cause mortality increases. So without doing anything, the higher your coronary artery calcium score, the higher the risk. So now, kind of taking it back to that patient with established ASCVD, if you have some coronary artery calcium data prior to when they had their event, you can get a sense on, whoa, their calcium score was X. They are at high residual risk. And now they've obviously had an event. And so we need to be even more conscientious of that person's risk for future events. This is, again, a very nice study comparing the interplay of traditional risk factors with coronary calcium alone. And when I say traditional risk factors, I think about things like hypertension, diabetes, hyperlipidemia, smoking. And the only point I want to really come across on this slide is that if you have a patient with just no coronary artery calcium, so calcium is 0, but greater than or equal to 3 traditional risk factors. If you look here on the bottom right of my screen, the yellow bar, this is the risk of someone with 0 calcium with a lot of traditional risk factors compared to someone with maybe no traditional risk factors, the back left, but a calcium score of greater than 400. it goes to show how prognostically valuable a calcium score can be, because it really reclassifies someone's risk independent of traditional risk factors, which is also very, very important and telling. And we've also, with time, have created a risk calculator that incorporates the calcium score when you get it, to understand somebody's risk. And so if you look at someone's risk and there may be, let's say, intermediate, and you put in and you get a calcium score and it's elevated at 600, and you put that into this, you may find that their actual risk is much higher. And so, and this is just based on the MESA cohort. You can Google MESA, M-E-S-A, coronary artery calcification risk calculator, to get a assessment of risk incorporating the coronary artery calcium score. Okay, so we talked about residual risk, both in the primary prevention patient and also a patient with at secondary prevention, but also has some of these risk enhancer markers from the past that have been discovered. Well, what do we do? How do you treat that? Well, the first line of therapy is statin therapy. These are extremely well-studied drugs that have been out for a long time. Here, I just give a table of low, moderate, and high intensity statins, and kind of in sort of classical textbook types of LDL reduction. Now, I will say with anecdotal experience that I have placed people myself on lower doses of, let's say, rosuvastatin at 5 milligrams, and have had a profound LDL reduction, much more than what I would have expected based on sort of statistical estimates of how low we'd actually get the LDL. Some people tend to be hyperabsorbers. Some people may be on drugs that sort of lower the metabolism of statins, et cetera, et cetera. And so every patient is different. I just want to throw that caveat out there. But in general, this is sort of what we would expect with low intensity, moderate intensity, and high intensity statins in terms of LDL reduction. Now, high intensity statins are defined as rosuvastatin 20 to 40 milligrams a day, and atorvastatin 40 to 80 milligrams per day. Moderate intensity for atorvastatin and rosuvastatin, anything lower than that. And notice that in low intensity groups, that rosuvastatin and atorvastatin are not there. They are at the minimum moderate intensity statins. So if you have a patient with established ASCVD, currently the guidelines would recommend placing them on a high intensity statin. And so if you do that, you would choose from either rosuva 20 to 40 or atorvastatin 40 to 80. And a lot of that is based on what their LDL is pre-event, to if they've not been on statin. Of course, they've been on a statin, then optimizing the dose to get them to particular LDL-C thresholds, which I'll talk about. So, but if you're looking back at the primary prevention group in the intermediate or borderline risk, starting with the moderate intensity statin at first is very reasonable. And at high risk, starting at high intensity statin is also very reasonable. What about statin treatment based on coronary artery calcium score? So if you have a coronary artery calcium score of 0, assuming they have not had an event and assuming there are no other risk factors like familial hypercholesterolemia or an elevated lipoproteinuria or other biomarkers that are of concern, usually can monitor a patient just with good lifestyle modifications. Again, this is assuming they've not had an event. They do not have ASCVD. A calcium score between 1 and 99 favors statin therapy, and that greater than 100 or equal to 100, highly recommend to initiate statin therapy. How do you reassess lipids? And this is pertinent to both primary and secondary prevention patients. If you make an intervention, the guidelines would recommend reassessing lipids anywhere between 4 to 12 weeks from initiating a statin or a non-statin therapy even, just to make sure that you are reaching your threshold. And a routine measurement every 3 to 12 months is very reasonable. Fasting is generally not required unless you're concerned about triglycerides or other type of genetic dyslipidemias. But we also have patients who are statin intolerant, and statin intolerance is something that we've studied a lot and found that it's oftentimes not as frequent as we think based on studies that have looked at placebo effects or nocebo effects. However, in a patient's mind, it may be real. In a patient's mind, it may be something that's really impacting their quality of life. And so the definition that I personally like to use for statin intolerance, and this is based on the National Lipid Association, is the inability to tolerate at least 2 statins, one at least at the lowest starting dose due to objectionable symptoms or abnormal laboratory values that are temporarily related to the onset of statin use and resolve with statin discontinuation. And the more, in general, as uncommon as statin intolerance is truly based on the literature, the things that we see more often are myalgias at 3 to 5% rate, essentially cramping, stiffness, soreness, aching, usually bilateral of the proximal muscles. Myopathy, where you have a CK level that is 5 times the upper limit of normal. New onset diabetes, depending on what you read and based on what data that you're getting the information from, it's ranged anywhere from 9 to 27%, but probably much lower than 27%. And again, every study that has looked at this has seen that the benefit that you would gain by being on the statin far outweighs the small risk of developing new onset diabetes. And we've seen also that the new onset diabetes tends to be more so focused in subgroups that are already predisposed to insulin resistance. And hepatotoxicity, of course, defined as 3 times greater than the upper limit of normal in your liver enzymes. So how do we manage statin intolerance? In a primary prevention patient, it gets kind of hard. Again, I don't want to say hard. It's a little bit more nuanced. Certainly de-escalating the dose or trying an alternative statin or alternative dosing. Don't forget ezetimibe. Now, if they do have familial hypercholesterolemia, then moving towards a PCSK9 inhibitor is important. And then, of course, doing all this in addition to lifestyle modification. Now, remember, if the patient also has established atherosclerotic disease or maybe non-obstructive coronary disease or non-obstructive atherosclerotic disease, these are patients that are now with ASCVD, right, based on the definition. So they would benefit from being treated as secondary prevention. So in secondary prevention patients with established ASCVD, you can try an alternative high-intensity statin like atorvastatin if they were on rosuvastatin, or rosuvastatin if they were on atorvastatin, de-escalate the dose. But most of us in the prevention space, especially the lipid space, are moving towards alternative lipid-lowering therapies to add as an adjunct to statin. So adding ezetimibe or a PCSK9 inhibitor, most likely combination therapy. And so doing all of this in addition to lifestyle modifications is what would be recommended. So low threshold, if you can't tolerate at least 2 different statins at the maximal tolerated dose, or your LDL is just not getting to where it needs to be, then adding a non-statin such as ezetimibe or PCSK9 inhibitor is absolutely important. For familial hypercholesterolemia, I just kind of listed some of the more common mutations here of familial hypercholesterolemia at the LDL receptor level or at the ApoB level or the PCSK9 gain of function. This is a condition that is oftentimes underdiagnosed in our community, and if found early, extremely important to bring their LDL down, because a hallmark, at least clinically, of familial hypercholesterolemia is an LDL greater than 190. And of course, with the family history or early personal history of a cardiovascular event. So something to keep in mind, because if you intervene early on these patients, you can do them a lot of good. And so how we manage familial hypercholesterolemia and how we sort of intensify their LDL lowering therapy is we really want to focus on upfront high-intensity statin to bring the LDL down by 50% or to 100 or less, whichever is lower. If unsuccessful, adding ezetimibe, and if on combination therapy, or you just need to get the LDL down even lower and you don't think ezetimibe alone with the statin is going to cut it, or they are statin intolerant, going straight to a PCSK9 inhibitor. In secondary prevention, the threshold is less than 70 milligrams per deciliter, of course, just like it would be for anyone that doesn't have familial hypercholesterolemia but has established ASCVD. So kind of honing in on our secondary prevention patients, our established ASCVD patients. We really want to understand what that residual risk is. So that, in general, because this is a little bit busy slide, but in general, we want to bring their LDL at least to less than 70 milligrams per deciliter. Now, there's in the guidelines, they kind of go into classification of very high risk ASCVD and those not at very high risk. And a lot of that is based on comorbidities and age. And so I've listed here in this red box sort of the very high risk factors, right? So very strong family history, diabetes, persistently elevated LDL despite therapy, a history of heart failure, other complication of a myocardial infarction, older age, CKD. And so in general, we really like to bring the LDL down in our current guidelines here in the US to less than 70 milligrams per deciliter, but the lower the better in general if you have high risk. And in fact, there was a recent expert consensus decision pathway that has advocated for bringing the LDL cholesterol down to less than or equal to 55 in very high risk patients. And this is also consistent with European guidelines, what our colleagues in Europe are also advocating for. And in general, just thinking about a primary prevention patient, if they have risk factors like diabetes, endocrine societies are now advocating for an LDL cholesterol threshold to be less than 70, even in that groups who have not had an event, but just have high risk, like a patient with diabetes. So, but for an ASCVD patient, a patient at very high risk, loss of comorbidities, a strong family history, older age, really trying to push them to less than 55 if possible. And so what that sometimes means is that the statin alone may not be enough and that they may need upfront combination therapy to optimize their risk. So there's some novel agents that I definitely want to talk about here in the last few minutes of my presentation. That are FDA approved, and maybe a few others that are on the horizon. So in terms of, these are all LDL lowering therapies, and especially for patients who are secondary prevention. So there's bempedoic acid, which is a once daily oral non-statin therapy, which works upstream from the HMG-CoA reductase pathway, which is how statins work in the hepatocytes. And data has shown, early data of bempedoic acid, modest reduction in LDL-C. And it works well as an adjunct to statin. And as I will get to after the recent CLEAR Outcomes trial, it also seems to have a benefit in statin intolerant patients with established, both with established disease and actually without. And also bempedoic acid comes in a combination pill with ezetimibe. And so that's also an interesting sort of option for patients who are, let's say, are on ezetimibe already. They can't tolerate a statin, for instance, or they're on a statin. Instead of adding a third pill, you can, if they're already on ezetimibe, they're tolerating it well, you can potentially do a combination that includes the ezetimibe already there. Then there's inclisiran, which is an siRNA-based therapy targeting PCSK9. So effectively also a PCSK9 inhibitor, just not a monoclonal antibody like what is currently available in with evolocumab and alirocumab. The other thing about inclisiran that is unique is that at maintenance, it just requires one subcutaneous injection every 6 months. So the way it works is you can get a shot at day 0, then at 3 months, and then every 6 months after that. So for maintenance, you're going to be getting a shot twice a year to help lower your LDL. And based on the data that we do have, it can lower LDL-C up to about 60%. So this is just sort of a schematic on how bempedoic acid works. Bempedoic acid, as I mentioned, works upstream to the HMG-CoA reductase pathway. So don't know if you guys can see my mouse or not, but statins work here at HMGR. Bempedoic acid works up here. And the idea is that it prevents the development of various metabolites that can concentrate in skeletal muscle that may lead to intolerance symptoms. This is just data from the earlier Clear Wisdom trial that showed sort of the modest reduction in the LDL-C over time. Again, smaller trial compared to some others that we have more recently in the bempedoic acid space, but did just show us that this does reduce LDL. One of the things to just keep in mind, because everything we do really revolves around shared decision making, is just understanding the patient that you're starting bempedoic acid on. And one of the things in terms of its safety, it's relatively safe, but there was a signal towards increased gout flares in patients with established gout with bempedoic acid. But more exciting about bempedoic acid was really recently at the past American College of Cardiology scientific sessions, where the presentation of the CLEAR Outcomes trial was presented. This was a double-blind, randomized, placebo-controlled trial involving patients who were unable or unwilling to take statins due to statin intolerance. There was a total of about 14,000 patients who underwent randomization, about 7,000 assigned to bempedoic acid, and another about 7,000 assigned to placebo, with a median follow-up about 40.6 months. About 4,000 patients were in the primary prevention setting, so they've not had an event, and most of them, 70%, were established ASCVD patients. The primary endpoint was a 4-point composite of MACE, including death from a cardiovascular cause, non-fatal MI, non-fatal stroke, and coronary revascularization. And what you can see here, based on the Kaplan-Meier curves that I've showed, across 4-point component MACE, which is the primary endpoint, bempedoic acid did better than placebo in terms of reducing these events. Same with the 3-point composite, looking at just fatal or non-fatal MI, and just in terms of coronary vascularization. So there seemed to be a benefit in the statin intolerance population in reducing cardiovascular events with bempedoic acid. So just to give you some outcomes data, I share that really to provide outcomes data with some of the novel therapies that we have. The outcomes data with inclisiran is still in the works, but the LDL reduction is very profound. This is just a schematic of how it works. It's an siRNA molecule that works in the nucleus of our cells to inhibit PCSK9. Here's some data from both Orion 10 and Orion 11 showing the reduction in LDL-C of inclisiran. That you can see that there is pretty profound reduction across two different cohorts, Orion 10 and Orion 11. And so if we do believe, and many of us do, that reduction of LDL can lead to improved risk and reduced risk of cardiovascular events, then this certainly can be a very useful tool in our toolkit, in addition to many others. This is the oral PCSK9 inhibitor that is currently investigational, that is just another option for patients, found to be relatively safe and reduce PCSK9 by 90% and LDL up to 65%. And has, you can see here, that is very dose responsive. And then more recently at ACC 23, the phase 2B randomized clinical trial was presented that showed up to a 61% reduction in LDL compared to placebo, with no difference in adverse events between the two arms and good medication adherence. And this, importantly, this study included patients with ASCVD and uncontrolled LDL, and those without ASCVD, but at borderline or high risk. So very important, again, across all spectrums. Lastly, treatment that is currently available for homozygous FH patients with two mutated genes that lead to abnormal metabolism of cholesterol, is evinacumab, which is an angiopoietin-like 3 protein 3 inhibitor. Again, drops LDL in these patients by about 47 to 50%. So a lot of options out there, right? A lot of options in our toolkit, but there's a much bigger problem than drugs that can help us, right? The problem here is that we have all these cool tools, but many of our patients, many of our established ASCVD patients are not even on statin therapy. This is a study of patients across from 2019 onward, and it looked at over 600,000 patients with ASCVD. Almost about 50% of them were not on statin. Only 22.5% were on high intensity statin, and outside of statins, 27.6%. And those that were less likely to be on statin were females, those with a lot of comorbidities, or had cerebrovascular disease or PAD. So these are very high risk patients that are not covered with one of the most foundational therapies. So we need to do better as a society. So I'm really glad that we're having these talks to discuss how we can do that. And this is not just for statins either. This is a study our team did of over 700,000 patients with established ASCVD, and that looked at, from 2018 to 2021, the uptake of non-statin therapies like ezetimibe, PCSK9 inhibitors, icosapent ethyl. And what we found was that only 6% of patients were on ezetimibe, 1.6% were on PCSK9 inhibitors, and only 1.3% was on icosapent ethyl. With a small uptake over time, but this is as of 2021. So a lot of patients out there with uncontrolled LDL-C with low implementation of evidence-based therapy. So I think as a society, we certainly need to think about the barriers that we heard about earlier here that are leading to the lower amounts of implementation, because we know that these drugs can work. We just now have to figure out as a society how we can do better at getting them to our patients. So I'd like to conclude there. We have so many different strategies and options for lipid management. Important to remember, we have to reassess our LDL-C to make sure we are getting to the goal or the thresholds that we want. If we don't recheck, we won't know, and our patient may still be at high risk. It's important to personalize our strategy through shared decision-making with the patient, with guidance from the guidelines. Remember, every patient is different, and one thing may work for one patient, it may not work for the other. And we have a lot of opportunities to improve LDL-C management at the health system, provider, patient, and community levels. And I think we need to come together and collaborate across the spectrum here to really be effective in lowering LDL-C and optimizing risk in our established ASCVD patients. I'll conclude there. Thank you so much. And I've left my email on here if anyone has any questions, as well as my Twitter handle. I try to promote some educational material, a very good scientific material if anyone wants to review. And I'm open to any additional questions that we have here from the group. Thank you so much.
Thank you so much, Dr. Shah, for your presentation. At this time, I would like to encourage our participants to type their questions into the Q&A box. I did see a hand was raised earlier. All questions we ask to be directed to that Q&A box on your bottom toolbar. Our first question that we do have for you, Dr. Shah, is how do you manage LDL cholesterol in patients with elevated Lp(a)?
Very, very good question. So the way I do it, the way I look at elevated LPA, I view that as an extremely high marker of risk. And so I treat my patients who have not, let's say, had an event, but have elevated LPA as if they've had an event. So what that means is I really drop their LDL cholesterol as low as I possibly can within the means that I have in front of me. So high intensity statin, get their LDL as low as possible, definitely below 70 milligrams per deciliter at the minimum. I try to modify their other modifiable risk factors. So they're also hypertensive or they're obese, they have diabetes. I really am aggressive with those things. I really make sure a good diet and exercise regimen is being done. But yeah, to directly answer your question about LDL, I do everything I can to bring their LDL as low as I possibly can with the therapies that I have available.
Now, in that same vein, when do you screen for elevated LPA?
Excuse me. Yes, very good question. So the European guidelines recommend screening everyone once in a lifetime for elevated LPA. So I have a very low threshold to screen for elevated LPA. Excuse me. But more particularly, where I'm thinking about elevated LPA as being something to know about is in younger patients who have had events, people with extremely strong family history, people with familial hypercholesterolemia. We know that at least up to 20% of patients with familial hypercholesterolemia have elevated LPA. People who I just cannot get their LDL under control despite everything I'm doing. I check for LPA because 45% of the LPA core is LDL, and traditional lipid panels cannot distinguish between free LDL and the LDL that's attached to LPA. And so that's another group that I look for. And I think it's important in general to, if anyone has an interest in knowing what their LPA is, to screen for them too. And the reason I say that is because, one, if I know someone's LPA is elevated, I can do what I mentioned earlier, in that I know how aggressive I need to be with their LDL management. Oftentimes, depending on elevated levels and other risk factors, I look at their bleeding risk, and maybe this is a patient I also want to be on aspirin therapy if their bleeding risk is low, because I know they're extremely high residual risk. And then third, I have family screening implications, right? Like if I have a patient that has an elevated LPA, I definitely want their first degree relatives to be screened for LPA as well. So, the more we know about elevated LPA, the more important it is, because we can start preventative therapies earlier. And then of course, they can be on our radar for clinical trials that are currently being conducted that are testing either antisense oligonucleotides or siRNA-based therapies directly inhibiting lipoprotein A.
Wonderful, thank you. Next question, how can we improve the uptake of lipid-lowering therapies in the real world?
Great question. I think this is going to take a collaborative intervention between the health system, the patient, the provider, the community, because we are all in this together. We need to identify the disparities. We need to identify social determinants of health that are preventing our patients from getting the therapies that would benefit them the most. We need to look at access issues, like what's preventing a patient from getting this therapy. Is it cost? Are there assistance plans available either at the health system level or at the pharmaceutical company level? Are there barriers in terms of getting to a clinic? We need to think about transportation issues there. And then we also need to think about innovative ways of identifying people at risk. So one of the things that I'm very interested in is remote lipid monitoring. So when you think about, our providers that are out in the community, many of them are seeing 5 patients an hour. They may, have only a certain amount of time in a clinic visit, and they may have to focus their clinic visit on, let's say, back pain, or assuming it's the primary care provider, knee pain or some other comorbidity, and that they'll be like, all right, next visit, we'll look at your LDL. But by the time the next visit even happens, the patient who has residual risk might have had an event. And so remote lipid monitoring might be one innovative way of just using like a clinical champion. So like a clinical pharmacist, an APP, who's just screening patients through the EHR to see who's at risk, and if they have an LDL that's at goal or not, because this could be one way to identify them early, even make an intervention remotely, send a prescription to either optimize a statin or start a statin, and get that started early so that by the time they go back to their PCP and they get their LDL checked, they're at goal and their risk is reduced. So think about innovative ways. Other interesting ways of doing this is partnering with like common consumer organizations, so like Costco or grocery stores, or I don't have nothing. I have no stake in Costco. I just top of my head because probably have to go to Costco later. But just big grocery stores potentially to promote heart healthy diets and things like that. And so a lot of like innovative ways. Digital health is another booming area that we could utilize. So, remote monitors to, help us understand our cardiometabolic health. And then again, AI technology is really, really growing, and where, AI now can algorithmically screen large EHR data to identify the people at risk that we need to look at. So kind of becoming more precise in our management, identifying people early may be some innovative ways.
Great, thank you so much. Our next question, and we do have a couple of minutes left. So again, I encourage everybody to ask any questions that they might have of Dr. Shah into our Q&A box. The next question we have is, how can we help the transition of patients coming off an acute stay and managing their LDL, especially when dealing with many other urgent conditions or needs?
So the important thing is going to be just keeping an eye on, just having a note that we need to check an LDL. We need to check an LDL later in 3 months. Like once they started a treatment, we need to make sure that treatment's working. So having that note in on checking an LDL will be extremely important in 3 months. Making sure that the dose that of, let's say, a statin was appropriately dosed, so they don't need to go higher. They're not, if someone who's had an event didn't have a moderate intensity statin that was prescribed, if that's truly their maximally tolerated dose, they don't need to optimize. So just keeping those things in mind after an event, especially if they have a cardiovascular event, that's going to be extremely important on hospital follow-ups to make sure they're on all the right evidence-based therapies. Now, if you have other pressing issues, I think cross collaboration is important. I think that in my personal opinion, it's never too early to see a cardiologist. And so if you need to send them to cardiology or, send an e-consult or a staff message to a colleague, let's say you're a primary care provider, just to make sure everything is in check, just to kind of help take the load off of you because you're also managing some other important issues will be important as well. After an event, typically patients go to cardiac rehab. And so that's also a place where there's some safety nets to make sure their LDL is controlled. And so just keeping that on your radar, I think, is the best way to do it, and making sure there's a plan to address that LDL at some point, whether it's just a 3-month lipid panel to see how the statin they were initiated on inpatient is working, or phoning a friend or collaborating.
Thank you so much. I think we have time for one more question. Can you touch on best practices for challenging and re-challenging for statin intolerance?
Yeah, so that's a great question. So it really depends on if they're primary or secondary prevention. If they're secondary prevention, I would say don't try. My personal opinion is if they can't tolerate a statin, despite you trying a different statin, especially between atorvastatin and rosuvastatin, I would move straight to non-statin therapies like PCSK9 inhibitors. Ezetimibe is always your friend as well, and that it can be your friend in the primary prevention setting. For the primary prevention setting, I think that's where it becomes a little bit more challenging, where you may need to try the lowest dose of a particular statin to make sure they're tolerating it, switching, trying every other day. You can do that, or you can risk classify them further. You can get a calcium score to see, like, how aggressive do I really need to be? If they have elevated calcium, then they have ASCVD. And so just making sure they're not symptomatic from it. And because if they have ASCVD, then the whole window of opportunity opens up for you in doing non-statin therapies, looking to make sure they don't have FH, because then you can do more than just statins. But a minimally tolerated dose, finding one that works, and ezetimibe is going to be important. And I think with time, as the data keeps coming, it seems like more non-statin therapies are going to be coming into the primary prevention space. So those will also be available. But the biggest thing is just to understand how aggressively you need to treat the LDL, especially a primary prevention patient with some of those risk enhancers I mentioned. Compared to secondary prevention, you can just go straight to PCSK9 inhibitors if after intolerance to at least 1 or 2 statins.
Thank you so much. And thank you, Dr. Shah, for this insightful presentation. And thank you to our audience for your participation. Coming up next, we have 2 sessions starting at 1:30 Central Time. Session 4, Benefits of Integrating Pharmacists in ASCVD Management. And session 5, Alert, Can Clinical Decision Support Tools Prompt Better Quality ASCVD Care? At this time, please use the Return to Lobby link on your screen to choose your next session from the presentations list. Thank you very much for attending today's summit. We will see you shortly.